I'm John Hilton, Senior Editor for InsuranceNewsNet. Today, INN reporter Doug Bailey and I will be hosting a panel discussion on what has been described as the excess mortality trend that began with the COVID-19 pandemic. Joining us on the panel are members of the Insurance Collaboration to Save Lives. ICSL is a not-for-profit group deploying targeted screening, testing, and triage to identify those life insurance policyholders most at risk for sudden death or critical care incidents. Our panel includes Josh Sterling, founder of ICSL, Teresa Weiner, a life and health actuary for the state of Georgia's Commissioner of Insurance, and also an ICSL board member and treasurer, Mary Pat Campbell, Vice President of Insurance Research at Conning, and a member of the ICSL actuarial team, Dr. Edward Lanieski, an orthopedic surgeon with orthopedic regenerative specialists at Rehabilitation Physicians, and a member of the ICSL medical team, and Steve Siberan, ICSL product team leader. Welcome, everyone.
Thank you.
Thank you.
Now I want to turn it over to Doug to get us started. Doug?
Thanks, John. I guess we're all here to talk about something people don't really like to talk about much, and that's mortality. This started, the idea for this actually was back more than a year ago when we started going through insurance company financial reports, and we saw a trend that a lot of them were reported losses due to what they called excess mortality, which means that they were paying out settlements or more than they expected. But to put it crudely, more people died than they had calculated or anticipated. And during the pandemic, you would expect mortality rates to rise, but what we're seeing is that while they did decline, they managed to stay higher than pre-pandemic levels. And we want to know why. And I don't know if we've got that answer yet. And so that's partly what we're doing here today. What does it mean? What are the statistics? What does it mean for insurers? What does it mean for consumers? What does it mean for the medical and regulatory communities? Is this just a new normal, or is this part of a cyclical event? Or is mortality rates now going to remain high? You know, at the end of last year, the head of the FDA noticed a concurrent drop in life expectancy and said that this was indeed a catastrophe. Then he called for all hands on deck to try to mitigate it. And he said there's a role for government, for industry, for medical community, and for consumers to play a part. So we'll get underway with, I think we'll go right to Josh. You know, we'll get to, I think, the advocacy and goals of your organization at some point. But first, I want to just, if you could just give us an overall picture of what the mortality situation is, what it was, and what you think it's going to be. And then I'll ask you the question that I asked you the other day. Are we in a crisis?
You know, Doug, I appreciate the opportunity to be here today. I appreciate you guys reporting. I mean, not everybody's, well, I think it's changed. I think the time you began writing about this was something that was sort of an emerging story. And I think there's been a lot of like major news outlets that are starting to talk about it. So I guess the appropriate thing to do is say, you know, congratulations to you and your editors and your team to sort of being on, you know, following the news. And I want to say, and I don't want to sort of, I could talk a lot, but I'll just say a lot of us in the group came to this story from the same way. We were listening to insurance earnings reports. I used to be an insurance analyst. And so this is, I wouldn't say that I do it for fun, but like this is something I'm aware of. And so when people start talking about excess mortality, you know, and that's not something you ever hear life insurance companies ever in my entire career being an insurance analyst ever talk about, you know, that sort of led to questions. And so, you know, I'm going to be really, really brief, but I want to show just maybe because I don't know how to speak in words as well as I know how to speak in pictures. If I can show you one chart to sort of start the conversation, and this isn't my chart. this is from data from it's a website called usmortality.com. I figure it's useful for your audience to sort of, learn how to fish as opposed to be given the fish. But it's very similar to the work I started doing, and I know Mary Pat's the world expert in, using basically CDC data to be able to track like mortality by all sorts of different slices. What's great about this website is it makes it very easy for me to do it without doing any of the work. And so, I'm very happy to give them the visibility. But more importantly is what's on the picture. And if you can see this is an age standardized excess mortality. And so there's no one perfect way to calculate any of these numbers, but directionally what this is trying to do is control for like a standard population without changes in age demographics, and that also adjusts for the fact that like younger people don't die as much as older people and stuff. So it's sort of it's attempting to be a good apples to apples comparison. There are reasons maybe it's not as high as it could be, but big picture, this is a directionally very useful way of starting the analysis. And the so what is that obviously for 2 years look at these numbers. These are excess above a baseline. These were periods of time when we were seeing deaths that were like, this is monthly data. Month of December 2020 was 41% higher than it's supposed to be, right? Like, was this in September of 2021, was sort of a weird month for that. That was 39% higher than it was supposed to be. But luckily in 2022, it declined, but you're still in this like 10%, 12%, 11%, 14% in December 2022. These are big numbers. I mean, these are very stable. Recently, then in 2023, it's been more like 6%. And if the data is not mature yet for the more recent months, but in January so far, and I think this was probably updated yesterday because the numbers are a little different than they were the day before, a little bit higher. It's a 6.2% so far in January 2024. And like and then just to complete the story, you look back at 2019, well, these numbers are basically zero, some are above zero, some are below. 2018, same sort of thing.
That doesn't mean nobody was dying.
No. This is a derivative measure. This is the excess above the expected.
Right.
But what it means is that the model is probably reasonable, that it's based on, because it's sort of straddling the zero. Also, that's what normal looks like. And I want to answer your question. I don't think it's been popularized yet in the media the way that people did after the financial crisis, but I think the new normal is the right concept. Obviously, we hope this number goes back to zero this year. But, so far in January, it hasn't. And last year it was 6%. The year before that was 12. Maybe we're trending down. That would be lovely. That would be a reasonable conclusion from this data set. But, we're 4 years on the pandemic. And so I think it's a reasonable question. Is it a new normal? I think 4 years on, as a former stock analyst who's like gets judged every day, I'd say we're living in the new normal now. We're just not sure how long it's going to last.
Well, Josh, how is the normal, like the straight line at the bottom? We could just raise that. How is that the baseline?
You mean how did they calculate that? Or do you mean, are you sort of in a pithy way?
Is that always steady? Is that always?
Well, that was a forecasted trended thing based on the historical trends, if you look at it. But there's different ways to play with their website to get that. I couldn't do it for you in real time. But basically, they do a regression of like history to say this is where it should be. And the fact is, it's pretty good at predicting 2018 and 2019. But then what ended up happening is you imagine that straight line like this. 2020 went up way here, and then 2021 was about the same, and then 2022, and then 2023. But it's still above. And to your point, and this is where I thought maybe you're being pithy. We've kind of like elevated the baseline. So now the baseline seems like it's like 6%. Hopefully things get better. Dr. Lanuski talked about the biology, and Mary Pat and Teresa and Steve can talk about the actuarial perspectives on that. But, certainly we hope it's getting better. It's just that 4 years on we're still not back to where we were before.
One thing that I'd just like to add to that is in past pandemics, you see a pull forward of mortality, and then you see a valley for the mortality that was pulled forward.
Right.
And that usually is the next year. We're 4 years on, and we haven't seen any kind of a valley. And when you see an average of 12% increase, there's some age groups that are still 20% last year, still 20% up. And particularly, I think Mayor Peck could speak to this better, but I think in particular last year, it was the younger ages, 15 to 45. Mayor Peck can speak to what the real numbers are.
If I could share a much simpler graph. So let me try that, because this is the graph I just made.
Well, there's always someone who wants to try to make it simple.
Yeah, let me
Give it to the actuary, right?
Yes, and I'm developing this for the Nashville conference, by the way, Josh. So just FYI, because I had talked with Eric earlier. So let me explain what this is. This is the standardized 10-year age groups that the CDC gives, and this is all the CDC data. And I'm comparing 2022, and this is that finalized data, against 2019. I'm not doing any trending, nothing like that. This is very simple. And looking at, so these percentages is how much did that death rate step up from 2019 to 2022? And we saw, and I think we keep pounding this, that the worst relative increase in mortality has been in this group, 35 to 44 years old. But where is it coming from? Because you saw those huge peaks. Well, a lot of that was COVID deaths, and a lot of that was, rather old people. But now in 2022 and then into 2023, though this is just 2022 data, the purple is the COVID. And that's going to be primarily where most of the excess mortality is for the oldest age group, 85 plus. One of the groups, and we're not focusing on this for ICSL, is the external causes of death. And that really increased during the pandemic, and it's still heightened. And that's stuff like motor vehicle accident deaths and drug overdoses, the drug overdoses were already on a bad trend. And you can see that's a large contributor, that like 25 to 34-year-olds, that increased almost 20% in 2022 compared to 2019. Okay, so I'm sorry, I'm going to tell you, ignore those two bits, because COVID has come down quite a bit since 2020 and 2021, when it was the peak. External causes, motor vehicle accident deaths and drug overdoses, the insurance industry, it is affected, but how much the insurance industry can, influence that. A lot of it's public policy. But the yellow on the top, that's the other natural causes. That's our heart disease, diabetes, liver, kidney. We've seen all sorts of causes of death increase during the pandemic, and this is the 2022. And again, that 35 to 44-year-old group, they're like getting everything hitting them. And that's had the worst effect. So that combined, it's almost 30% increase in their death rate in 2022 compared to 2019. And this is a huge increase. And this is affecting life insurers, primarily group life insurers, because that's group life is a big employee benefit. And it's also affecting other lines of business, such as disability insurance, long-term care insurance, workers' comp. I mentioned motor vehicle accident deaths. That's in the red here. Auto insurance has been affected by these increased motor vehicle accidents and the deaths. So this is 2022. In 2023, these other natural causes, that's what's contributing to that continuing about 6% excess mortality. It's not just COVID.
So we can't blame the phenomenon on long COVID or anything like that.
Well, some of those other natural causes, maybe it is long COVID. We don't know, because it's not necessarily going to be COVID on the death certificates. All of this is based on underlying cause of death, where it's the one and only one major driver of what caused the death. There can be contributing causes of death on the death certificate, but I'm not using that in my analysis for right now. So there can be COVID, but long COVID is, it's still in its infancy and being investigated.
And Mary Pat, if I could just make one little tiny comment there about
Yeah,
the
sorry.
external causes. The
Mhm.
definitely depression is up. Depression
Yeah.
leads to drugs and drinking.
Suicide.
Well,
Suicide.
yeah, and also the alcohol related deaths are also up quite a
Yeah.
bit. So I'm not putting that on here. Yeah, there's a
So,
lot of bad stuff in there for the external causes. And
but
I
the
don't like
external,
talking about this. Suicide has got a very weird pattern as well.
the
Yeah,
external
so we're not
causes.
focusing on that. Sorry.
Yeah.
Yeah,
I know you're not focusing on, but the
yeah,
external causes could be
yeah.
part of long COVID, since one of the major
Oh, yes. Yeah, yeah.
symptoms of long COVID is depression.
Yeah, and from an insurance company point of view, I mean, all of this goes into it. I keep saying dead is dead. If you're life insurer, disability insurer, long-term care, whatever, it will have an impact. A death will have an impact one way or another. So,
Right, and the group life COVID-19 mortality study from the
yes.
actuaries mirrors that age banding similarities, even though it's not exactly the same as the U.S. population, but it's insured lives. So.
Right. The Society of Actuaries has been really on this in doing experience studies for both individual life insurance and group life insurance. And of course, they're underwritten in different ways, but they have been reflecting and they have been splitting out COVID versus non-COVID impacts. And they have been finding excess mortality from non-COVID sources. So that has been an interesting, into 2023, even as COVID has come down, because some of it was positing, oh, well, heart disease maybe because COVID is causing, some heart disease problems, or they're not going to the doctor. We saw utilization go down quite a bit in healthcare utilization go down in 2020 and 2021. That people weren't going to the doctors who should have, or even older people who needed help to get to appointments. Well, they lost their ride, perhaps. So that was some of the things they were positing. But now, as we're getting into 2023 and 2024, that can't be the explanation so much anymore.
But it seems like this would all argue for a temporary outreach or effect of the COVID. I mean, automobile accidents were up, suicides were up, drug addictions was up, and a lot of it was attributed to the pandemic period. But I guess we go to the medical.
Yeah, I'm sorry. I'm just saying we didn't really see them come down a lot during 2023. This is 2022. And as Josh was showing, we're still seeing persistent excess mortality from our 2023 data as well. It's really not come down a lot. So this is concerning.
Yeah, and the one thing I'd just like to add on there is long COVID isn't necessarily a diagnosis, but it's more of a collection of symptoms. Right. And there's other underlying health issues that are driving that. And we're seeing, as the mortality data shows, is it is affecting a lot of your major systems that Dr. Laniewski could probably speak to better, but it is affecting your circulatory, your skin, it's affecting cancers and a lot of other things because of what it's done to your immune system, et cetera.
That's just what I was going to say. I was going to hand it over to Dr. Laniewski and say, are we in a period of, has our immunity systems become more vulnerable, or is it, do you see signs of this being a long-term effect? And I also have to add, every time we write a story about this, I get inundated with letters that say they know what the cause is. It's the vaccine that's causing all this. So if you could talk about that as well.
Well, this is great. So I kind of look at big trends. I'm not anywhere near these other guys on the panel here. I basically flunked out of statistics, but but I still look at bigger trends. But I wanted to share something with you, if I could, something I think is quite interesting. And it's basically off the same data that ICSL has here. And what I did notice was that, I'm still seeing patients, and I would have patients that would come in and ask me to shut the door and want to tell me about their symptoms that they're having that are unusual. And I thought that was something to investigate. And so luckily I was put onto this committee here and started looking at this. And this is the Mary Pat's diagram here that I decided to go ahead and share with my patients here. And not only show that there's an increase in death, but also an increase in disability. And for the first time ever, we've seen a decrease in our life expectancy by quite a bit, So you have to think about what are the causes of that, and are we done with this? Is this something that we can just say, oh, this is something in the past and just shut the book on it? Or is that something coming up? And on one of the things I had up here was about the double bump. So I always like to look back at history, and in 2018, the Spanish flu and the H1N1 both had a double bump. What do I mean by a double bump? Is where you have an increase in mortality, you have a short pause, and then you have another increase in mortality, usually lower than the first one, and then the pandemic is over. Well, we had the increase, but we haven't had the second bump. And you have to think about why. And usually that bump comes between about 8 to 10 months. And it's definitely been a lot longer. So there must be something going on with our immune systems. And it could be, I don't know for sure, but it could be that we were all vaccinated during the pandemic, which is not normal. Normally, when you go to a country that say has yellow fever, I just came back from Kenya last week, you get vaccinated before you go to Kenya. Why? Because when you're in Kenya, it's not very effective to get vaccinated there. So here in the midst of a pandemic, we all get vaccinated. And that does something a little bit different to the response of the human to the virus that extends the length of the viral infection, maybe a lot lower and less deadly. But now you have this thing called a viral escape, and all those viruses that are escaping may come back to bite us at some point, maybe.
What do you mean by viral escape?
Okay, so let's just use the example about antibiotics, right? When you're given a dose of antibiotics, what does that doctor tell you all the time? Make sure you take all of them. Why? Because if you only take like 2 days worth, well, then you get resistant organisms, right? And then they have to use a different type of antibiotic, and eventually they run out of types of antibiotics. So what that means is that bacteria escapes, right? It doesn't get killed, it escapes. So same thing when we artificially stimulate our immune systems to simulate a spike protein, there are certain T cells. T cells are the ones that give us that memory that says, hey, I've seen you before. Those kind of escape. They escape. And we don't get fully immune to that system. So that's why it's always said that people that have had natural immunity, somebody who has, say, had yellow fever, or somebody who has had COVID, has a complete immune system. And numerous studies have shown that definitely natural immunity is better than the immunity given by a vaccine. So now you've got these escaped viruses that are out there, and maybe they may come back and bite us and give us a second wave, because we have not had that second wave, possibly.
So maybe get an insurance underwriting perspective here. What does this do to the calculations or of trying to determine the mortality rates going forward. I don't know who wants to take that one.
I'll take it if I can be flippant, because I'm not the underwriter or the actuary here. But the problem with life insurance is you got to make these plans. Most of your policies you're pricing for 30 years in advance. And so you have to make these estimates based on historical trends. And for something like 500 years, mortality's been improving. And so those estimates are really stable and generally going down very slowly over time. That's been a really easy trend for the insurance industry to model. What's very unclear is where that trend goes for today. And there was a couple of months back we published a study, or wasn't a study, but we published a chart where we had taken a survey at the Society of Actuaries conference, and we asked actuaries, how many of them thought mortality was continuing to be elevated, and roughly I think it was about 80% thought in a couple of years out it would sort of come down. And we asked that same exact question, or we didn't ask the question, someone else asked the same question the year before. And you had the same exact number of people saying that, well, a couple of years out, it's going to come down. And so, there's a part of me that feels like, again, and I'm saying being flippant, but like serious in a real way, life insurance is very hard to model the future around things you don't know. And like for those in the life insurance world, long-term care for 30 years, people were mispricing, and then they always thought they were right just around the corner, and we just got it right, but it turns out we didn't. And 30 years after it was done, all of a sudden GE fires its CEO because it turns out they still have like business that people didn't even know about. And so I kind of think, again, I'm a little flippant, I'm a stock analyst, I think about big picture here, but when I look at these numbers, I'm like, I see an inflection change. And now it's positive. It's positive beyond expectations. The industry wants it to come down. We hope it comes down. Our group got together because we're like, well, what if it doesn't? And what should we be doing right now to try to help it come down? And so, that's sort of how I think about it.
Right. And so there's been actually a few changes here we have to think about in the accounting for GAAP for life insurance recently. We had the targeted improvements for long duration contracts. Once upon a time, those mortality assumptions were locked in at issue. And unless the reserves for the life insurance contracts went deficient in some way, you kept them. And that was for all sorts of assumptions. But now you're supposed to keep them up to date, at least annually. And so if there is a new normal for mortality, then those reserves will have to be updated and perhaps raised annually if it turns out the mortality is worse than you had expected. The GE example on that long-term care, yeah, that was when they had known about it for, if I remember correctly, for over a decade or about a decade before they fixed it. They let some of the excess losses flow through as extraordinary items, I believe, until they finally recognized, oh, by the way, we have to restate reserves. That's a big thing. These targeted improvements in GAAP were for life insurance, or actually just, it's not just life insurance, but just the long duration contracts, which covers life insurance and some other related products. This was to prevent that sort of situation from occurring, that you keep all your valuation assumptions up to date. So this has more than just the pricing and underwriting impact. This affects how you're looking at your in-force business. And that's part of our argument, is that what actuaries have done in the past on the life and annuity side is, let's look at these statistics, let's look at the past, and we're just modeling how it's going to go. We're kind of passive viewers of what's going to happen. Versus, and Josh mentioned this, at the beginning of insurance in general, it was property and casualty fire insurance. Part of the function of the fire insurance companies, like with Ben Franklin, was to help reduce the risk, not just insure it. So, you know, that they weren't just going to sit there and like, oh, by the way, I see all these hazards, but I'm not going to help you reduce that. I mean, they had fire engines, and you had your boss or whatever that you put the plaque that you put on the building to, if a fire broke out, but also do inspections, give you tips. How do you reduce that? Let's put some lightning rods on your buildings, whatever it had to happen to reduce the risks. So now some of the things that we're doing, and other people should talk about this, is what are some cost-effective tests to identify hidden risks that they may not know about. So that's one of the issues, and this is why I'm starting to look at early onset cancer, is that there's a lot of people, young adults, early middle age, who are not aware of some of the health risks that they may have of early death. And some of the interventions might be relatively simple. Everybody knows quit smoking, lose weight, that kind of thing, but there are other ones that are more subtle.
Yeah, like I just want to add on that is just the impact of when somebody dies 2 or 3 years early, well, what they were 10 years early from when they should have. You've now paid out of assets that were contributed, that were supporting your reserves. You're losing that extra 10 years of premium that they would have paid. And you now have the cost of replacing that policyholder, which some of the insurers are telling me could be 100 times that first year premium. And that's a lot of impact for that insurance company. And there's other factors too, but that's a huge cost. And when we get to
it can have a lot bigger impact at younger ages than at the older ages too.
Yeah. And to get to Mary Pat's point about look at other forms of actuarial science, they all do some mitigation of in-force policyholders, whether it's property casualty, health insurance, disability insurance. Life insurance is like one of, if not the only area that doesn't do much of anything to mitigate the risk of in-force policyholders. And there are simple things that can be done to do that in a cost-effective way.
And that might be, due to, in the past, we've always had mortality improvements. It's just been projected forward, and people are questioning that now. Even if it has gradually come down, it was still about 0.5% to 1% a year. So that, and even for reserving, so.
And some of that was just coasting on population tendencies with regards to reduction in smoking. That did a lot, frankly, in reducing mortality. So I've mentioned that I was on the project oversight group for the US population experience, general population experience at the Society of Actuaries, and we got that started before the pandemic started. And one of the reasons we were doing that was that it was understood more sophisticated mortality projection models were needed because mortality improvement was not being uniform across ages. There were life insurance companies that found they were getting bad mortality experience, and bad mortality experience just means it was worse than you expected. It could have improved, but it improved less than you expected, and that would be bad mortality experience. And that was happening in the early 2010s. And I was seeing that with heart disease, that wasn't improving like it used to. And what's going on with that? So we were trying to develop, teasing apart trends by different age groups and by sex, and that different causes of death, like Alzheimer's disease and some other ones, were actually getting worse, other than the ones that we knew about, like drug overdoses. So we knew about that one. But there were natural causes of death where the trend was not what we thought it had been, and it was affecting our overall, the aggregate trend. So now with the pandemic, we found that it got exacerbated, like really bad. So this might be, when we say new normal, maybe it got reset to a worse position and the trend might not go back to where it was before. But at the Society of Actuaries, like, I'm going to keep plugging them because they've done a lot of work. They've had a couple research papers where they said, well, what is excess mortality anyway? Should we have continued the trend, which was improving in aggregate overall, and then we have a much bigger excess mortality measure in the pandemic than what I've been showing you here, by the way? Should we do it by individual cause of death? Should, you know, different choices? And you might make a choice depending on what kind of insurance, you know, what the application is in a model. So my application was trying to educate the public. So I was keeping it simple. And I said 2019 was a boring year for mortality. There wasn't anything really going on with seasonal flu. So I didn't even average prior years. Prior years, there was a really bad seasonal flu year. I didn't want to include that. But others have. So, you know, there's different choices to make.
I'd just like to comment about, so with actuaries and all the stuff that Mary Pat does and what Josh has looked at and Teresa's looked at, that's all stuff that's all, again, history. I'm on the front lines. I'm seeing patients all the time. And I'm on my other job that I have, I'm a medical officer for a pharmaceutical company that treats cancer. And I'm at the end, I'm the compassionate use doctor that, you know, patients that have had cancer, have had 4 or 5 treatments, they're not getting anywhere, or their cancer comes back, they come back and they petition us to use our drug that's in trial. So there's a new law that was passed, right to try and those type of things, so that the patients can actually access this. So when we first started that, it was, you know, maybe 1 or 2 people a month, you know, that would contact us. Now it's 4 or 5 a week. They usually have the same story. Also, in my normal practice that I see patients face to face, I will tell you that there are a lot of patients that come in and have other conditions, especially like blood clots, strokes, that I just didn't see before. So those will take some time to become recorded. And especially with cancer, you won't see a death, you know, for maybe 4 or 5 years. So that's going to lag behind. So, you know, you have to take 2 aspects of this, somebody who's actually looking at the numbers from behind, and people that are looking at trends that are occurring in their day-to-day practice. My personal feeling is I think that we really haven't hit bottom. I think we're going to see another spike.
Seems like we're playing some kind of whack-a-mole with symptoms. Like, you know, we got on top of smoking, maybe we got on top of diabetes, but it seems like I'm seeing statistics that show an unusual increase in things like pancreatic cancer. And the other day, the Times had a story that said they're seeing an unusual increase in abdominal or colon cancer among young people. You know, people in their late teens and 20s getting colon cancer.
I just had a good friend of mine that his son just died of that. Rapidly, you know. So it does happen. And skin cancer too. I mean, there's a huge increase in skin cancer, which again, we're not going to see the results of that, you know, on paper until later on. And, you know, speaking of things that we can do, though, it's about our immune systems, right? So our immune systems have been, I think they've been damaged. You know, it's very interesting, very interesting. If I took lab rats and I took the lab rats themselves and I separated them out and I isolated them because rats need to live together. If you separate them out, they get diseases. They get a lot of autoimmune diseases. So they get colds, they get flus. But when you put them together, their symptoms go down. So the isolation issue is, you know, played a little havoc on our immune system. There's other things that were, you know, given to us, done to us that maybe even mask wearing actually increase our risk for immune disorders. But now our immune systems are damaged. So what do we do to go ahead and fix those? Real basic things, real basic things of what we discovered in that small cohort that we looked at, or 29 patients, looking at like vitamin D level. I would say, I tell every single one of my patients, I was an osteoporosis expert before, go ahead and everyone should take vitamin D. And I would say at this point that everyone take a bare minimum of 5,000 international units a day. And I would actually dare to say that you should be up to around 10,000 international units a day, because you need to get that vitamin D level up into the 70s, not the 30s, but into the 70s, to actually affect your immune system, because vitamin D is one of those great supplements that do two things, but you really need it at 70 to affect your immune system. Another is that you've always been told before, vitamin C, but you really want to be in that 3,000 milligram range. And zinc, 35 milligrams. So those three together will help with your immune system and help stabilize that wobbling immune system.
Well, that may bring us to what the collaborative is doing and how you got started, and where you see the weak points are that you want to try to take advantage of. And what are you doing?
Well, thank you, Doug. We were a bunch of insurance nerds who came together, who were looking at the mortality trends, learning about how to do the analysis. We started talking to doctors who started educating us about some of the science and, their understandings about from the front lines of what was happening. And we realized there was an opportunity for the life insurance industry in particular, but generally insurers, take a play to take, including PNC, certainly supplemental, certainly disability, certainly employee benefits, basically to take a more targeted, data-driven approach to try to make a difference. And, what we're doing basically is, our mission is to engage and empower global insurers to address excess mortality and save 1 million lives through screening, testing, and triaging their at-risk members. What does that mean in practice? We would like insurance companies to allow to provide low-cost blood testing to be available for their members, so they can get tested for what we believe are the 4 or 5 things that are most helpful to address, which are typically not things people are aware of, which are but are either some which are addressable through a lot of times changes in their own lifestyle, but in some cases require medical care or possibly require medical further investigation and then possible care. In any case, the idea would be is that you could actually prevent both a lot of short-term harms like strokes, like heart attacks, like pulmonary embolisms. All these things are really, like blood clots was mentioned. These things are all up right now. I think there was a congressperson just yesterday that was in the news for that kind of thing. And those are like very short-term acute events, which are costly to the benefits community, terrible for employers when their employees go out, obviously, and incredibly costly to life insurance companies when these people are insured lives, because these are basically leading to death. But that same testing can also drive very, huge impact over time through cumulative impact on like shorter, like longer fuses, or like, less acute issues, like diabetes or pre-diabetes, like sort of the more typical heart disease that people, we had to deal with before COVID, as opposed to the more acute stuff. It seems like it's a thing now, as well as, to be honest, immune system and possible sort of risk for cancer. And these are things that make a real difference in people's lives. And, like Dr. Leniewski said, ultimately a lot of these things can be addressed through some supplements, which, we're not in the business of selling, but you can buy them at Walmart. It's not super complicated. Usually this is just something that people don't know about. Right. And so if we can provide a little bit of education, a little bit of guidance, use the vast resources of the insurance industry, I think we can reduce some of these, sort of sudden deaths that like are driving a lot of costs and are certainly driving sort of social loss, lots of social loss. That's the opportunity we see. And we're talking to lots of insurance companies about this. We've got employer groups that are interested. We've got a couple of national branded companies we're in, I would say, serious conversations with that, all your viewers would, would certainly have heard of for sure. Big television advertisers, those kinds of people, as well as some global companies that are like talking about deploying it in Europe or in Southeast Asia.
I was going to ask,
like,
I was
think
going
there's
to
a lot of
ask Josh,
opportunity here.
I was going to ask George, we tend to be a little solipsistic and we focus on the US and stuff, but this is a global phenomena, is it not? And are there areas of the world where it's worse, or areas of the world that are better that we might be able to learn from, that you know of?
Yes. Well, do you want to say anything, Josh?
I don't have all the answers. It's a great question. It's not something we prepared before. I will tell you though, and I learned this from Mary Pat and others in this journey, we in some ways in the United States are among the most in need of this kind of thing, because we have had poor mortality trends relative to other Western developed countries for like a decade. And probably if it wasn't for the benefit, because Mary Pat's very smart about this, if it wasn't for the benefit of smoking going down for so long in advance, it would even show as worse for a long time. And so we can then talk about like what might drive that and social differences and health and diet and do we have maybe, we don't have good healthcare insurance system, but we also as a society consume a ton of healthcare, maybe more than other places. There's a lot of different possible contributing factors. I don't have the answers to what it is, but I think right here might be the place in the world that is the most would benefit the most from this effort. But I don't have to have the last word on that for sure.
Yeah. So yes, there is a trend. I look at mortality trends across the world and different countries, and it does seem like Africa, especially like Central Africa, is lower death rates, especially during the COVID pandemic. Some of the Norwegian countries were also lower rates. We still haven't recovered. Other countries that have also mirrored us are like Israel, very similar to ours. The reasons why we don't know for sure, but it's very interesting about COVID policies during that time.
Also, within the US, you can see in the group study, the society did this survey. The Southeast is really bad, especially Georgia is one of the worst. So, and I do think that variations by obesity and rate of diabetes, and there's so many factors, also hit minorities harder, or different things that may vary by state, because I'm trying to compare red and blue states, but I think it's more about the demographics personally, but it's
and we keep plugging this. Teresa and I are members, we were fellows of the Society of Actuaries, that one of the dashboards that comes out of that US population mortality study is by socioeconomic quintile. We categorize every single county because the CDC data actually comes out at the county level. And then we do a socioeconomic score for each county, and and then we aggregate it and make 5 groupings, 5 quintiles. And there is such an obvious difference in mortality results by socioeconomic quintile. The lowest quintile just has been having bad mortality experience for decades, well before the pandemic, and for a variety of reasons. And the 5th quintile, so the top socioeconomic quintile, the richest, most educated counties, tend to have been doing a lot better, and during the pandemic actually did a lot better. So there have been differences, and there are geographic clusters going on there too. Just like Teresa was saying, there's some geographic differences as well.
And a lot of that, though, is lifestyle related in that.
Yes, diabetes, obesity, yes,
so
absolutely.
And the pandemic hit those people that were in worse health a lot harder. So I think that is a big contributing factor, and probably what you're seeing in some of those socioeconomic and geographic data.
And where that comes out is in the group life insurance experience more than the individual life insurance experience.
Yeah, even some of the even
Yeah,
some of the insurers that we've talked to that are focusing on more the high income brackets, and they do good underwriting for a lot of these things, they weren't affected as much as some of those that were these broader insurance policies, et cetera.
Yeah, so the middle market was more affected versus that high net worth, high income. That is correct.
Yeah, so I would disagree on one point about the monetary aspect of it. I think it's a health aspect of it.
Yes.
Because look at Central Africa. Their yearly income is equal to 1 month's salary here easily. So I don't know if it's that, but I do think it's, again, you remember we talked about immune system. So diabetes and obesity definitely affect the immune system and the monocyte production, and all that stuff that make you more susceptible to mortality with COVID. So I think that's more about it. And I would suggest, again, everybody that's listening to this, work on your immune system.
Yeah, I completely agree. And that was my point, is I think when you see those socioeconomic, those people that are making more, they're more likely to eat healthier food and be physically active. Whereas those people in the lower socioeconomic, it is probably their lack of health and their lack of interest and ability to do some of those things that's made them more susceptible. So I'm right in agreement with you there.
Obesity is tied to that in in the US, but not in Africa, whereas you probably don't have the obese issue in the low socioeconomic as you do in the States.
We've talked a lot about mortality, and that's super important, but there's actually also a lot of people who are sicker. I'm wondering if you want to talk a little bit about disability.
You mentioned that earlier. I was going to ask you about that.
I would love to show a quick chart, if in part just for your viewers. Here we go. Again, I like to show. Well, sorry, this is not to differentiate. This is a chart that anybody can go to. The Department of Labor puts out, and the St. Louis Federal Reserve has a great website called Fred that you can get like all sorts of economic indicators off of, and like cool charting tools and whatever. Obviously, because I was an analyst, this kind of thing I would look at. But this is a survey that the Department of Labor runs every month when they also call to figure out who's employed and who's not. So every first Friday they update these numbers. They started doing it in 2008, so we don't have older than that. But they did it for a long. They've done it for a long time now, and it's not a perfect study. It doesn't have like a million different variables, but basically this is the list. This is the total amount of people over the age of 16 in the United States who answered someone from the Department of Labor calling and saying, is there someone in your home who's disabled right now? Who has like a certain number of criteria who makes them disabled. It's not about whether they're getting paid or not, on disability policies or anything like that. It's not a claim. It's just a self-reported survey. And what you can see, this bar is at the end of the COVID recession. That's how the software puts it on there. Is it 100? You can see that actually now we're about 113. So that means 13% higher. And there was a really big increase in the number of people, in, I guess this is 21 or 22, it really increased a lot, over that period of time. And if I could just flip, what's really interesting beyond that, this is now the civilian labor force. So these are only people who are disabled, but still either working or trying to work. Like the first group would have included like either homemakers or people who are not in the labor force, retired or on support social services or something. This is people who are working or trying to work. Look at the scale of this chart. Similar sort of thing. It's a little bit delayed, but stable.
Yeah.
But this is 139, so 39% higher. That's kind of nuts. And then they give it to us by gender. And I don't really know what to make of this, except that this is what the number is. If you look at it for just women in the labor force or trying to work, it's actually like, if you can see it, it's 158%. So it's 58% higher than it was for the pandemic, from which for about 10 years before was really kind of stable. And so I don't know exactly what these numbers mean, but I have interpreted them as a measure that they update every month as a very, very rough gauge of the level of like sort of suffering and health problems that people are having on a chronic basis in this country. Those numbers represent about 34 million people.
That's a great, great, great point, because what do? You get sick first, right?
Yeah,
And then you die. So,
Yeah.
yeah. And the mortality for these disabled
Well-
lives is a much higher than for the general population by a significant factor.
On Wall Street, you would call this a leading indicator.
Yes.
Deaths are a lagging indicator, and you
Yeah.
use the leading indicator to predict the lagging indicator. Unfortunately, that's sort of where we are. The idea with this group is, hey, there's a problem. We're not sure how big it's going to be, and we're not sure how long it's going to last, but we should try to address it before it works its way fully through the system. Because there's people we're talking about here, as well as, the financial opportunity for insurers for sure. But like at the end of the day, these are like our friends and family. And, everybody involved in this feels like we have some greater duty to try to help in some fashion, for
And-
whatever reason, we're all doing that.
And those graphs that Josh shared, it's not clear that we've hit the top. We didn't see any coming down to normalization
Right.
at all. So that to me is also a disturbing trend.
If your goal is to save 1 million lives, and your goal is to try to like make the world a better place and help the insurance industry avoid what could be like a train wreck in years to come, like it doesn't really matter what caused this problem. What matters is we should have like a Manhattan Project run by the insurance industry to try to figure out what's going on with current health and try to make it better.
I think we can wrap this up. This is really interesting and a bit chilling. And I think I heard the expression "good mortality experience," which I never heard before.
Doug, can I just add
I'm
one
sorry, that
thing?
is it is an expression, that your A to E ratio is, below 100. That's good. It's just, it's compared to what you expected. That's all
No,
that
I
good
know.
versus
I know.
bad. That's
Just-
it.
Doug, can I just add one more point? Because I know we talked about all these things, and there is a cost to doing this screen test triage that we talked about. We did create an impact model looking at the post-pandemic versus pre-pandemic model, and to try to understand, well, does it make financial sense to invest in something like this? And a lot of that depends on where, what kind of policies you have, and what the level of policies are, and kind of what your population looks like. But based on some of the simple modeling we did, is you could, if your average policy size is like 200,000, you could invest probably about $100 per person to get them screened, tested, and triaged, and you could break even. If you go up to 500,000, you could invest not only $100 for the screening, but also maybe another 150 or so in the triage aspect of it. So depending on your policy size, you might invest more or less, and maybe it's just an incentive to go get it done,
Right.
make it available, and say, look, it's your cost, but we'll invest so for some of the smaller policy size. So you could use kind of a segmented approach for your book of business to do something that makes cost-effective sense, while also enhancing the experience of those policyholders if you do it right. So I wanted to make sure that didn't get missed.
That's great.
Doug,
Anything else?
I wonder if I might give you one piece of hopefully good news for your viewers. One of the biggest constant stream ever since we put up our website has been emails asking, where can I get the tests? Where can I get the tests? How can I help? How can I've got concerned about somebody in my family, whatever. These are the emails we get. We're going to be announcing soon, and it's going to be on our website, an ability to buy for about $150, the package of tests. And we're not doing it because we're becoming a testing company. We're not focused on like making money off of this. In fact, I think we're not going to get paid at all in this process. We're really just facilitating it. We're doing this because we want to have a way to answer the emails from the real people who need help. And because we're going to go around and ask everybody who's a senior leader in the insurance industry, which is, if you haven't tested your team yet, why haven't you tested them? Because these are the people that you count on in your business, and you guys need to be the leaders. So you can go figure out what you need to do for your team, and then you can do that for your customers. And we're going to make it really easy. And, ultimately it's, for everyone's benefit. There's nothing like seeing it happen for real and in your personal experience that can make a difference in your health. And then as a leader deciding to sort of roll that out in a broader group. I mean, that's been what we found in our team. A lot of examples, people, myself included, who health's improved dramatically from a result of going through our process about a year ago when we did our pilot. So
just to build on
hopefully
that,
that'll be soon.
and to build on that, we've also done a request for information of a lot of the InsurTech, health tech type companies, so that we could identify those that have something unique or have the ability to support the broader screen test triage approach. And we're reviewing those. We're going to be meeting with those companies and hopefully make other broader solutions available to the marketplace as well. And certainly so that we could help insurance companies with custom solutions for specific to their needs and their policyholders.
I'd like to say this about being an employer. This is opening week for baseball, right? And a lot of times, as an employer, we would take all our employees down to like the Detroit Tigers game. That would cost us about $200 per person easily. You add in drinks and everything. I was like 250, 300. And I asked them, what would you rather have? A Tigers game paid for, or to get your health tested? And by far, 9-1 wanted to get tested, because that means a lot more to them. That's their life. That's the life of their loved one. So
that's the ultimate irony too. If you can demonstrate that it's a low cost solution to this problem, really, if you think about it in terms of volume, it's pretty incredible.